Okay, thanks. So the issue with the bleeding patient is a lethal triad, and it encompasses progressive coagulopathy, core hypothermia, and metabolic acidosis. And this is when things really spiral out of control. So this is a schematic of the bloody vicious cycle, a bit traumatic, but this is what happens. And here we have an inciting event of a major torso trauma, and which is causing active hemorrhage. So the hemorrhage, there are iatrogenic factors that cause core hypothermia. This is when like, ambient temperature, the infusion of cold blood products or crystalloid solutions, you have decreased, also opening body cavities during emergent surgical procedures. That's going to cause core hypothermia, which causes progressive coagulopathy. The hemorrhage itself obviously causes cellular shock. You're going to have decreased heat production, and the shock state is going to cause core hypothermia and metabolic acidosis because of the hypoperfusion. The trauma causes tissue injury, which is going to activate the intrinsic pathway or contact activation, which is going to cause progressive coagulopathy. Massive transfusion itself causes contact activation and progressive coagulopathy. It's also going to, you can have clotting factor deficiencies, particularly when you're just giving PRBCs and not other factors and platelets. Patients with pre-existing diseases, patients who are on anticoagulants, who have liver disease or bleeding diaphyses, they're going to have clotting factor deficiencies and progressive coagulopathy. And you can see how you're just going around and around and everything is spiraling out of control, which is why you can have uncontrolled bleeding if you haven't achieved hemostasis. So this is a study from 2003 examining injury-induced coagulopathy. There were over 1,000 patients with an injury severity score of 20, and 57% had injury severity score greater than 15. So for those of you who are unfamiliar with the injury severity score, 75 is considered unsurvivable, 15 to 20 is considered severe and like polytrauma. So this is, again examining patients' coagulation profile before crystalloid fluid. And they found that the higher the injury of severity score, as you can see on the graph on the left, the more patients had coagulopathy. And then the graph on the right, the patients who had who were coagulopathic compared to normal had a significant increase in mortality. So the incidence of coagulopathy increased with severity of injury and was unrelated to IVF. And this just further illustrates the coagulopathy associated with ongoing hemorrhage. And it's called, again, in the trauma setting, acute traumatic coagulopathy, or ETIC, which is early trauma-induced coagulopathy. And the process is the coagulopathy potentiates bleeding and is associated with an increased mortality. And it does this because early tissue hypoperfusion upregulates thrombomodulin, binds thrombin, activates protein C, and activates factors 5 and 8, and your clot generation is impaired. Activated protein C depletes plasminogen activator inhibitor. You have unrestrained tissue plasminogen activator, plasmin generation, and clot lysis, which is fibrinolysis, and you can have a hyperfibrinolytic state. Plasmin degrades fibrinogen and depletes your fibrinogen stores. And I want you to just pay attention to the plasminogen activator inhibitor, because this is when we use tranexamic acid, which I'll talk about later. But TXA is a plasminogen activator inhibitor, and then will decrease fibrinolysis. I know the pathway is a bit painful, but that's just a little overview. And the incidence of hyperfibrinolysis in trauma patients is variable, but portends a high mortality. So traditionally, patients were resuscitated with isotonic fluids, plasma-poor RBCs, in order to achieve euvolemia and tissue oxygen supply, and labs were followed, and people would just receive blood products based on the laboratory profile. And this caused dilutional coagulopathy, accelerated by hypothermia, causes acidosis, ischemic hepatitis, you have DIC due to tissue injury, and increased consumption of factors and platelets at wound sites. And it's important to know that the most early deaths due to hemorrhage occur within 2 to 3 hours. This is a landmark study by Borgman, and it was a retrospective review of 246 trauma patients, and they examined plasma to RBC ratios. So leftmost, you have a low plasma to PRBC ratio, you have medium in the center, and then high. And mortality significantly varied between low, medium, and high ratios of plasma to PRBCs. And the hemorrhage mortality rates were 92% versus 78% in the medium group and 37% in the high group. And this was done in 2007. And this was reflecting our clinical practice guidelines in trauma and combat, but this was just proving what they were doing as far as giving higher plasma to RBC ratios increased survival. Other retrospective studies suggested higher plasma and platelet ratios, which occurred in about 25 to 50% massively transfused patients and was associated with at least a 50% decrease in mortality relative to lower ratios. The problem, though, is there was no consensus about how to transfuse patients because the evidence, these are retrospective studies, it's not high quality, and the survival bias, like I mentioned. So contrary to the traditional resuscitative approach, there is something called damage control resuscitation, and it's been a clinical practice guideline since 2004. And this favors early administration of blood products in fixed ratios, 1 to 1 to 1, to approximate whole blood. The aim of this is to prevent and immediately correct coagulopathy, minimize the use of crystalloid fluids, and also employ permissive hypertension, which is like a systolic blood pressure between 90 to 100 or a MAP of 60 to decrease bleeding. Studies show varying outcomes when applied to civilian trauma centers, but again, this is something that's been going on for decades with respect to trauma and military settings. And this is an article from The Lancet in 2015, and it's the medical response to the terrorist attacks in Paris, and this is how they approached the traumas. And they did damage control, which consisted of maintaining blood pressure at the lowest level of consciousness by using tourniquets, vasoconstrictors, antifibrinolytic agents like TXA, and prevention of temperature lowering instead of fluid filling. And just a reminder that 130 people died in these attacks, fortunately. So for the 1 to 1 ratio, or the higher plasma and platelet to PRBC ratios, there's been very few studies, but this is one study, the top one from 2008. It was a prospective cohort study over 2 years, looked at 365 patients. And 250 patients received both PRBCs and SFP versus 115 patients who only received PRBCs. And they also had 81 patients in dual transfusion group who received massive transfusion, and 51 patients received products in a 1-to-1 fashion. They found that PRBC to SFP ratio did not predict ICU days. Regression analysis showed no difference in mortality, controlling for age, gender, injury severity score, presence of head injury, laparotomy, or Apache scores, and ICU length of stay. Subsequently, there was a study out of Canada by Halle in 2013. It was a systematic review, looked at 7 observational studies, no RCT. So again, these are just poor samples. Primary outcomes that were examined were early and late mortality. Secondary outcomes were the presence of multiple organ failure, lung injury, and sepsis. And there was insufficient evidence to strongly support use of precise platelet to PRBC ratios for trauma resuscitation. Now, moving forward, Holcomb et al. In 2013 did a study called PROMPT, the Prospective Observational Multicenter Major Trauma Transfusion. And this was the first prospective multi-center observational cohort study documenting transfusions during active resuscitation and looking at patient outcomes. And they enrolled 1,245 patients, and they described what components were infused, and they assessed the association between in-hospital mortality and timing and the amount of blood products. So basically, they just were examining patients who were being transfused, and they just observed what was being transfused and when, observational only. They analyzed 905 patients. The overall in-hospital mortality was 25%, and they observed that 94% of hemorrhagic deaths occurred within 24 hours, and 60% occurred within 3 hours. Patients didn't receive a constant ratio during the period of active resuscitation, varied, but they found that early infusion of higher plasma and platelet ratios were associated with a decreased mortality within 6 hours of admission, during which 81% of hemorrhagic deaths occurred. And the ratios were not associated with a risk of death after 24 hours. And here you can see there's a plasma to RBC ratio on the left and a graph of the platelet to PRBC ratio on the right. And it's just showing that within 3 hours, looking at the graph on the left, most patients received plasma to PRBCs at a ratio of 1 to 2 or higher, again within 3 hours. And platelets on the graph on the right, most patients were received platelets to PRBCs at higher ratios within 6 hours. So the trend was that patients were given plasma more or earlier, and platelets were given, but it was within 6 hours. So Hefner prompt became the proper trial. I think most of us have heard about it. This was a landmark study because it was the first RCT looking at the ratios of products. It was by the same trauma researchers, Holcomb, and it was a proper trial. It was a pragmatic, multi-center RCT of 680 severely injured patients who were predicted to require massive transfusion. For the eligibility criteria to be included, the patients had to receive at least 1 unit of any blood component transfused prior to arrival or within 1 hour of admission. And they were predicted to receive the massive transfusion by ABC score, which is assessment of blood consumption, of 2 or more, or based on trauma physician's judgment. And I'll go over the AB score in a couple slides later. So the primary outcome was, there were 2, 24-hour and 30-day all-cause mortality. The ancillary outcomes they examined were time to hemostasis, blood product volumes transfused, complications, the incidence of surgical procedures, and functional status. 338 patients received blood product ratios in 1:1:1 fashion, and 342 patients received ratios of 1:1 to 2. So again, it's plasma, platelets, and RBCs. And then they also got whatever standard of care the institution was doing at that time. They didn't control for other pharmacologic or other interventions. They found that more patients in the 1:1:1 group achieved hemostasis with a p-value 0.06, and fewer died of exsanguination within 24 hours, in the first 24 hours, with a p-value significant of 0.03. But there was no difference in mortality at 24 hours or at 30 days, which were their primary outcomes. They found that the 1:1:1 group received more plasma and platelets, but did not have an increase in complications, which are the common ones, including ARDS, multiple organ failure, venous thrombus, embolism, and transfusion-related complications. So no mortality difference. But they did find that the median time to hemorrhagic death was 2.3 hours, which you can see on the Kaplan-Meier curve on the left, that most people were dying within 3 hours, and that was not an endpoint that they studied. So moving forward, or just talking about other interventions that you can do for the massively transfused patient is tranexamic acid. The biggest study was the CRASH-2 study, and this was done in reported in 2010, and it was huge. There were 20,000 patients who were at risk for bleeding, and they were randomized to either tranexamic acid or placebo. 35% of the deaths were due to bleeding. They found that the effect of tranexamic acid on death due to bleeding varied according to time from injury to treatment, and early treatment, meaning less than 1 hour from the injury, significantly reduced risk of death from bleeding in the TXA group versus placebo, and treatment within 1 to 3 hours reduced risk of death due to bleeding, and treatment after 3 hours increased risk of death due to bleeding. So this was significant because we have a mortality with a survival benefit within 1 to 3 hours, but it increases mortality after 3 hours, so the therapeutic window is narrow. And this is thought that at this time maybe there's just tranexamic acid can potentiate the bleeding because the patients are then becoming, have worsening, or becoming like hyper coagulable, and then, or potentiates the bleeding. And just a reminder that tranexamic acid is a plasminogen activator inhibitor. That's its pathway, but also can have thought to have anti-inflammatory effects. So it's not well understood, but the time to give the medication, that window, is between 1 to 3 hours based on this study. Following the CRASH-2 study is something called the MATTERS study, which is the top one, Morrison et al. It's the military application of TXA in trauma emergency resuscitation. It was a retrospective observational study, and the outcomes they looked at were mortality at 24 hours, 48 hours, and 30 days. Looking at postoperative coagulopathy and rate of thromboembolic complications. The TXA group had lower mortality than patients who did not receive TXA, despite being more severely injured, and the greatest benefit in patients massively transfused who received TXA was independently associated with survival and less coagulopathy. There was also a meta-analysis in 2011. They looked at 252 trials and over 250,000 patients, showed antifibrinolysis with tranexamic acid and aminocaproic acid reduces blood loss and blood transfusions and free of serious adverse side effects. So big benefit with a little risk. So as far as predicting massive transfusion, a lot of it is clinical judgment and experience, and there are a few scoring systems. Previously there was something called the trauma-associated severe hemorrhage score, or TASH. It looked at 7 independent variables that are weighted, but it was cumbersome, and it's not used anymore. But the variables they looked at are blood pressure, gender, hemoglobin, the FAST, pulse, base excess, and extremity or pelvic fractures. Another scoring system is something called the McLaughlin score, looking at heart rate, systolic blood pressure, pH, and hematocrit levels. But the score that's recommended to use is the assessment of blood consumption, or ABC score. And there are 4 components that you're evaluating when you have a trauma patient. One is penetrating mechanism. 1 point if there is a penetrating mechanism. Systolic blood pressure of 90 or less, you get 1 point. Heart rate of 120 or greater, 1 point. And a positive FAST exam, 1 point. If the score is 2 or more, it was highly predictive of the need for massive transfusion. And it was as good as a predictor as the TASH and McLaughlin scores, and a lot easier to use. So this is favored as a scoring system and is used in the trauma literature. So because of the necessity of expeditious blood product delivery, massive transfusion protocols have been implemented, and they are associated with decreased mortality and morbidity. And a good protocol should address the following: when and who should initiate the protocol, whether it's nurse-driven, doctor-driven, the notification of transfusion service and the lab for activation and deactivation. This is so you're not wasting blood products and things are returned in a timely fashion. A lab testing algorithm. Transfusion packages, what your cooler is going to contain, and other patient care needs. So this is the nursing staff. It can be a rapid infuser, a warming blankets. All of that should be addressed in the protocol. And when evaluating the outcomes with the massive transfusion protocol, there's a few studies. The first one is by Cotton from the 2013, they looked at, or sorry, 2009, compared outcomes in patients with massive transfusion pre and post implementation of the protocol to determine whether the protocol is associated with increased organ failure. They found a reduction of multiple organ failure and infectious complications, and an increase in ventilator-free days and reduction in open abdomen. So even though the patients got the blood sooner, overall they had fewer transfusion requirements. So they were able to have a reduction in abdominal compartment syndrome. If they went for laparotomies, the abdomen was able to be closed. And this had better outcomes because, you know, an open abdomen has a lot of complications. So they were able to reduce that in the patients who got the massive transfusion protocol. There's another study because, again, it's the MTP is more frequently seen in trauma patients, and the McDaniel study looked at patients when massive transfusion protocol in trauma versus non-trauma patients, and they were expecting that there would be more waste with the medical patients when the transfusion protocol was activated. So it was a retrospective analysis of 164 of non-trauma patients in the general medical service, and they wanted to see if it could be used effectively without impacting resource allocation. So they did find that the protocol was overactivated in 53.8% of patients, but there were no unique disadvantages with this use respect to resources. So products were issued more quickly and with less variability, and even though the products ultimately weren't used, they were sent back, and the amount of platelet waste was similar to the trauma activations. So it just highlights the need that if you're not going to use the product, send it back right away to the blood bank. But the importance is there wasn't a difference between the protocol being initiated by medicine doctors versus surgeons, and it was expected that there would be a difference. This is another study about massive transfusion protocols from 2009, and here they were examining what happened before the protocol was implemented and afterwards. So the protocol was started at their institution in 2005, and products were transfused 1 to 1.5, and it was level 1 trauma center, and they looked at data 2 years before the protocol was initiated and 2 years post. And they found no change in ratio of products transfused, but significant decrease in mortality in minutes to first transfusion. So this just highlights that the culture already was to give products in a one-to-one fashion, but the protocol got the products to the patient faster, and that decreased mortality. So again, it's just extrapolating to, you know, door to balloon time for STEMIs, or onset of stroke symptoms of TPA. That time is really of immense value and decreases mortality. So we have a protocol at Monty, and it was last revised in 2014, and this is for medical and surgical trauma patients. And our protocol is, if you activate the transfusion, massive transfusion protocol, you're going to receive 10 units of PRBCs, 6 of FFP, and 2 single donor platelets. That's the first time you activate it. If you're doing a second round, they will get ready the same ratio of products, 10, 6, and 2. So this is not 1 to 1 to 1. This is like 1 to 1.6. But again, because there isn't high quality evidence, this is what our protocol is. But you can certainly give the products 1 to 1 to 1 as you see fit. And we have a separate protocol for obstetrical hemorrhage. The products are released 6 units of PRBCs, 4 units of FFP, and 2 platelets, and this is about 1 to 1.5. You can give cryo if you want. You just have to request it. It's not going to come with your cooler. And obstetrical hemorrhage is managed a little bit differently because patients who are pregnant, they have higher fibrinogen levels, and when their fibrinogen level decreases below 400, they have higher risk of bleeding. So that's why these patients are managed differently, and that's been studied in obstetrical patients. But as far as fibrinogen levels in medicine patients or all trauma patients, we don't have hard and fast guidelines for the fibrinogen level that you want. We tend to say over 100. There is some variability with cardiac and neurosurgical patients. They tend to bleed more with fibrinogen levels less than 200. So as far as what other people are doing, these are some examples of other packages of the massive transfusion protocols account for. And I think there isn't a lot of variability. The first item is 10 to 4 to 2. Second one is 6 RBCs and 6 plasma. Platelets aren't included until the second package is coming. The third line, 5 RBCs to 2 plasma. And moving down the list, you can see there's 10 PRBCs, 6 plasma, 2 platelets, which is what we have. Lastly, you have 6 PRBCs, 4 plasma, 1 a platelet. Packages are repeated. Interestingly, the recombinant factor 7A is based on physician's request. However, in trauma patients, recombinant factor 7A can have worse outcomes and be like prothrombotic. So it is not recommended to give, and it's based on the clinician's discretion. I've never used recombinant factor 7A here at Monty. I'd have to ask the surgical team if they're using it, but I haven't seen it. Did you use it? Is that in the emergency room? Okay. So another way you can manage the bleeding patient is with point of care or viscoelastic testing. And this is called thromboelastography, TEG, which is what we have here, or there's thromboelastometry, ROTEM. And I'm just going to focus on the TEG because it is what we have at this institution. And both are doing the same thing, it's just a different mechanism. And the nice thing about this test is because everyone's coagulation profile is different, so you can guide your therapy based on the patient and not a lot of guesswork. So it's quick, it's done at the patient's temperature, and you can detect hyperfibrinolysis. And you're looking at all phases of the coagulation process with this test. The initiation of the clot, the propagation of the clot, and the lysis of the clot. And it can help you define timing of FFP and platelet and guide your therapy with coag factor concentrates like fibrinogen, PCC, and recombinant factor 7A. Again, I'm not advocating for recombinant factor 7A, but some people are doing it. And overall, you can reduce the transfusion of blood products. So the TEG, the way it's done is there's a little cup and you put the blood in the cup and there's a pin in the middle, and then the cup oscillates around the pin. The pin is attached to a computer and a tracing. And as the clot forms, the little pin is going to spin out a tracing. And looking at the tracing can tell you how the clot is being formed and what products might be deficient. So this is, topmost is what the tracing is going to look like. So the R is the time of latency from the time that the blood was placed in the little cup or the analyzer until the initial fibrin formation. So this is when your clotting factors are at play. Alpha is an angle. It measures the rapidity or kinetics of the fibrin buildup and cross-linking, which is the speed of the clot strengthening. So this is going to be depend on your fibrinogen levels. K, it's a measure of the rapidity to reach a certain level of clot strength. So again, that depends on fibrinogen. NA is your maximum amplitude. It's a function of the properties of fibrin and platelet bonding and represents the strength of the fibrin clot. So that depends on your platelet count and function. And then the LY30 is the lysis time, and that is the rate of amplitude reduction 30 minutes after the maximum amplitude. And this is going to give you an idea of the stability of the clot and if the patient is hyperfibrinolytic or not. Does that make sense? I'm going to go over what the tracings look like for abnormal profiles in a few slides. So this graph, again, it's just saying, the table is saying the same thing. So you have the TEG, the R value, K value, alpha, maximum amplitude, and LY or lysis. The ROTEM, they're just giving you the different, it's the same thing, it's just labeled differently. And the intervention for abnormalities in these values is on the right-hand side of the column. So if you have a prolonged R time, you're going to give plasma. If you have a prolonged K time, you can give cryo to get the fibrinogen level up. If you have a low alpha, you can give cryo. If the maximum amplitude is low, you would consider platelet transfusion or plasma or cryo if the patient is deficient in certain factors. And if the lysis, the LY30, if it's over 8%, that's considered hyperfibrinolytic, and you would give antifibrinolytic medication like TXA. And you could also give aminocaproic acid, but that's not studied as well as TXA, so that's why TXA is used more, especially given the evidence from the CRASH-2 study and MATTER study. So here are some normal tracing and abnormal tracings. So you can see top on the left, this is what a normal TEG tracing with normal platelet, clotting factors, fibrinogen levels, what it looks like. And then you can see on the right if the patient's thrombocytopenic or if it's just plasma, which doesn't have any platelets, you're going to see what the tracing looks like. Then you can see the heparin-coumadin effect. So you see how the R is prolonged. Hypercoagulation, you see a big, thick MA or maximum amplitude. You can see fibrinolysis, bottom left. So you put it in, it spits it out, and you have something within 30 minutes, and you can really tailor your therapy to the patient's needs. So that's why this is favored to use. However, not all institutions have it. Some EDs do. I think it's about 10% of trauma centers use the TEG or ROTAM. Here, because we have a lot of cardiac surgery, when we do transplants, that's where you're going to see it when patients are in the OR. They routinely are checking TEGs. And we have done it for some of the MICU patients. We have, we've sent it and just kind of to help guide our therapy. We don't do it routinely, but it is something we have at our disposal, and they should be running the TEGs through 24 hours. So this is one study from 2011, German study, and they looked at, again, retrospective, so not the best quality, but they looked at the need for RBCs or platelet transfusion in patients treated with TEM-guided hemostatic therapy with fibrinogen and or PCC and no FFP versus patients receiving FFP but no fibrinogen or PCC. And they found that RBC transfusion was avoided in 29% of the patients in the fibrinogen PCC group compared with 3% in the FFP group, and platelets were avoided in 91% of patients receiving fibrinogen PCC versus patients who were just receiving FFP. So we know that products are not without their complications, and if you can avoid the transfusion of allogeneic blood products, patients can benefit, possibly. However, a systematic review, looking at randomized controlled trials, looking at the TEG or ROTAM versus standard treatment of patients at risk for bleeding. Their primary outcome was all-cause mortality. Secondary outcomes examined were blood loss, amount of products transfused, proportion of transfused patients, adverse events, incidence of surgical reintervention, and duration of mechanical ventilation and length of stay. This systematic review showed no statistically significant effects on overall mortality, but there was a statistically significant effect on the amount of bleeding. Outcome was uncertain. More research needed was the conclusion for advocating for using this type of testing or not. So again, it's not standard of care yet. As far as complications from blood transfusion, you can see, basically anything. There can be allergic complications, obviously hemolytic reactions. You have immunologic reactions. There's trolley. This is the most, the complication that has the highest mortality, but it's underreported and underdiagnosed frequently. TRIM is transfusion-related immunomodulation from the effect of the blood product. This is why patients can have worsening infectious processes is attributed to the immunomodulation by the blood product itself. You can have transfusion-associated graft versus host disease. There's also something called post-transfusion purpura, which I've never seen. I don't know if anyone else has. The treatment, if somebody has it, is IVIG or plasma exchange or steroids. And there can be multiple other adverse events, hemostatic defects, infection, TACO, transfusion-associated circulatory overload, and also air embolism can happen, especially with a rapid infuser. So people need to know how to prep that. And those are complications you always have to watch out for. There is also something called a biochemical storage lesion, and you can see in the picture what the RBC looks like on day 1 and day 35. So there's no uncertainty that the PRBC undergoes these changes the longer that it's stored. So there's morphologic changes and also biochemical changes. Morphologically, the RBCs can be less flexible, they can be more adhesive and sticky. And there was a meta-analysis in 2012 that said that old blood had a worse increased mortality. Subsequent studies have disproven that. So even though this storage lesion exists, there has been no outcome on transfusion-related effects. So this old blood versus new blood thing is not of clinical importance. Hasn't been proven to be of clinical importance just yet, if ever. And you can see any kind of metabolic complication from blood transfusion. Hypocalcemia, we all know because of the citrate that's used. You can be hypomagnesemic. This can be because patients are being infused a lot of magnesium-poor fluid, also related to the citrate overload. You can have hyperkalemia. This is from lysis of the stored blood. You can also be hypokalemic. This is because the potassium levels can re-enter the cells, and also when you have the metabolic alkalosis, which is from citrate metabolism. Metabolic alkalosis happens, again, because citrate is metabolized in the liver. And you can be acidotic from the shock state. Also, the patients with liver disease can't metabolize the citrate, so they're going to be acidotic. And also hypothermia from infusion of cold products. So you should really use warmers whenever you can. So again, I have to emphasize that the data is extremely poor, and we don't have any for medical patients. We're extrapolating from the trauma population. Things that you can take away is that with regard to mortality benefit, transfusion of higher ratios of FFP and platelets within 6 hours of admission with massive hemorrhage may reduce mortality. You should use a scoring system to trigger a massive transfusion protocol for trauma patients at risk for major hemorrhage. And for our medical patients, should have the clinical judgment whenever to use it. So you just want to order it so you have the blood products that can be delivered expeditiously. TXA should be given within 3 hours of injury. And again, over 3 hours, there's increased mortality effects, so you need to be mindful of the time. And, most importantly, is rigorous research is needed, because most of this is based on clinician experience and not level 1 data. That's it. Does anybody have any questions about what to do? Yeah.
I was just wondering, where are our rapid transfusers?
The rapid infuser?
Yeah.
So what I've seen is what will happen for patients that we resuscitate on the floor, some people go to the OR and get it.
Okay.
It's a bit of a cluster.
Yeah.
Always.
Yeah.
What I've noticed, I've used it maybe 4 times on the floor, and usually it's the patient with the terrible ulcer disease, and there's usually a surgeon around and they'll run get it.
Yeah.
I never got it myself, so I can't tell you exactly where, but they are in-house. And even in the emergency room, they tend to not know where it is.
Yeah. So that's always the number 1 issue that I've had, is locating the device.
I know. And then you don't know how to use it.
Yeah. And then the tubing, not able to find that.
Yes.
So, that's the major practical thing. We can put, yeah. All right.
It has to be streamlined.
Yeah.
And it really isn't here.
Mm.
But my answer is OR.
OR, yeah.
Trying to come back to,
yeah.
So sometimes our patients come in with GI bleed. You don't know when they started bleeding. So how do you determine when to use it? If the spike suggests that.
So good question. So, honestly, I am not doing tranexamic acid for the GI bleed. If I had the tag and it was showing the patient was hyperfibrinolytic, okay, I would. I just don't do it. So this is unlike obstetrical hemorrhage. They're giving a lot of TXA. And I gave it maybe 2 times over the last 3 years for somebody with like refractory bleeding. But these aren't like penetrating injuries, you know, so it's really hard to say like, okay, is this patient going to have a benefit from it? So we're not using it a ton. But at Weiler, where you have a lot of the, you're going to see most of the obstetrical cases, have a very low threshold to give it. And again, it's because the pregnant patients, you know, can, with obstetrical hemorrhage, are usually hyperfibrinolytic, and TXA can be of real benefit to them. And again, like if the trauma, I guess if you have like an in-hospital trauma and you know that that happened within 3 hours, you can give it. We're just seeing that so rarely.
The second thing, sometimes you go into a room and you think the patient's gonna need like 10 units of blood, and it turns out that they needed like 3 or 4. Should you, like, if you go in there and you suspect that it's massive, should you just activate the protocol immediately?
Yeah.
Or would you wait until, okay. And then if you do and you don't use it, they will just
send it back.
Okay.
Yeah, that I can't overemphasize. Just activate it. So, and then you can just send the stuff back when you need. And usually, you know, you have, at least in the NICU, you'll have like a lot of, you know, residents and interns. You always send them to get the cooler. We start infusing, and then I have them send it back. Just because there can be like, you know, so much delay.
I understood. That's really the trauma intern's job is to get lots of it.
Yeah.
Yeah.
And there was, from the proper study, there have been a lot of other studies looking at outcomes, and they found that the cooler time, you know, there's a 5% increase in mortality every minute the cooler is delayed or the transfusion protocol is activated. Just activate it. Again, the waste is, as long as you're conscientious of it, should be minimal or nil. And, you know, the biggest thing is getting hemostasis. And then you're concurrently like transfusing, but like we had this, there was this GI patient on the floor who got like 21 units of blood, and like went for like definitive therapy, like, you know, hours later. I mean, that was just like, you know, what happened. But there's risks with over transfusing too. So we don't want like hemoglobins of 12. We want to keep it 8 to 2, and you're just keeping an eye on all of that.
There was this new study in CCM from Pittsburgh for non-medical. It was just like retrospective of, they said, of a prospective observational cohort.
Okay.
And it was like GI bleed, like non-trauma.
Okay.
And this one, they found like a high, like, so not matching 1-to-1, where FFP was not associated with any increased 30-day mortality. And then they found a higher mortality in people in 48 hours who got matched platelets 1-to-1.
Really?
For non-trauma, yeah. So, and the conclusion was like, you know, it's different, you know, different beasts and like different comorbidities for reasons for bleeding, and really specific. I mean, that was the conclusion from these authors.
Which one is that?
It was August 2017 in CCM.
Okay.
Neil is the main guy, Matthew Neil.
Okay.
And it's called "Should All Massively Transfused Patients Be Treated Equally? An Analysis of Massive Transfusion Ratios in Non-Trauma Setting at UPitt."
And increased mortality in when you're matching PRBCs to platelet.
Yeah.
No decrease in mortality.
No change, no difference with FFP.
FFP to RBC ratio.
Yeah, so you could go like one to a half.
Okay.
Yeah, for FFP, and not doing 1-to-1 where platelets showed improved mortality at 48 days.
Oh.
I mean 48 hours. 48 hours.
Improved?
Improved, so giving less platelets.
Right.
Yeah.
Okay. Well, thank you.
Intriguing.
Thank you. I looked. I didn't see that study. Thank you. I did a quick.
It is paid. So it's classified.
Yeah. That's the thing. That's why it's so like really overplaying the trauma patient, medical patient, and completely different.
You gotta look. Yeah.
I don't know.
So much else to control for it. Uremia, like.
Absolutely.
Yeah, cirrhosis, and then, I mean, it's so hard.
Yep. Agreed.
Cool.
Anybody else have any comments?